So we are live now. A very good afternoon to everyone. This is Batul, the moderator for today's session from IGCP, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our renowned stalwart who is present here with us today. Well, sir needs no introduction, but yet it's our great pleasure and honor to introduce him. He is none other than the very renowned Dr. Urman Roop, sir. Sir is MBBS, MD in Internal Medicine, Director Internal Medicine and Diabetes at HCG Hospital, Ahmedabad. With such wonderful insights, we're going to talk about the topic for today, which is Evolving Perspectives, NAFLD or MSLD in Clinical Practice. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. So over to you. Please proceed.
Thanks a lot, ma'am. Thanks for introduction. And this is Dr. Urmendru. Greetings to all of you. This is how we are going to talk today. This is our agenda, MASLD nomenclature. From there to the strengths and limitation of new nomenclature. So let's begin with the old terminology, which is NAFLD, which is actually an umbrella term which covers steatosis. It also covers ballooning and inflammation, which means it covers deposition of fat to the inflammation across the liver, which may ultimately result in cirrhosis, decompensated cirrhosis, hepatocellular carcinoma, liver transplantation, and mortality. Then there was a time when people realized that this NAFLD, that is non-alcoholic fatty liver disease, includes two terminology, alcohol and fatty, which are attached with some stigmata. So that was one important reason why the name was changed. And what's the new name? The new name is MASLD. Are they both absolutely equal? No, they are not equal. Very close by, very similar, but not equal. It was on June 24, 2023, that multiple organizations came together to decide the new terminology, which is now known as steatotic liver disease, SLD. And it means more than 5% of fat. And fat in liver is generally in the form of triglycerides. So you can say more than 5% of triglycerides in the liver is known as steatotic liver disease. The primary objective was to link the replacement nosology to the underlying presumed pathology. So as I said, they are nearly close but not the same. The reason is the pathophysiology now have been understood to be little bit different. It was critical for increasing disease awareness, driving policy change, identifying those at risk, and that is the most important change between the two, and facilitating diagnosis and access to the care. What do MASLD contain? MASLD is defined as the presence of hepatic steatosis with one or more of the cardiometabolic risk factors and no other identifiable cause of steatosis. The definition itself says that you need to rule out identifiable causes of steatosis, including the alcoholic liver disease. So, without mentioning alcohol in its definition, the definition rules out alcohol as one of the culprits for MASLD. You also need to include one of the cardiometabolic risk factors, which they are, we'll see. NASH, that was non-alcoholic steatohepatitis, was replaced by MASH, NAFL was replaced by MAFL, so on and so forth. So now we'll see what is the spectrum of SLD, that is steatotic liver disease. And this is a very wonderful graph one can see, which would show you how to progress or how to go ahead for the just a minute. How to go ahead for diagnosis. So you can see, how do you find out hepatic steatosis? Either by histology or by radiology or by non-invasive markers or by histology or radiology when it comes to MASLD. If the person is taking alcohol less than 30 grams, male, or less than 20 grams per day, You need to exclude other causes and call it NAFLD. If the patient is overweight, meaning thereby BMI more than 25 kgs, it would become MAFLD, which means MAFLD is NAFLD plus high BMI. Can there be a lean or normal weight MAFLD? Yes, it could be, but it requires two of these five metabolic risk factors. So, if any two of them are present, along with leanness, in absence of obesity, we saw here obesity is required for MAFLD, but even a lean person with two of these factors would also be called MAFLD. So, MAFLD could be overweight or could be lean. Type 2 diabetes, obviously, it itself, in absence of obesity, would be MAFLD. So, MAFLD would be either an obese person with hepatic steatosis or a lean person having hepatic steatosis with two metabolic risk factor, or a patient having diabetes with hepatic steatosis would be MAFLD. So on and so forth are the definition for MASLD. If a person is consuming alcohol more than 30 to 50 grams per day, he would be labeled as MET ALD, and then alcohol consumption would also change the ALD. So these are few ways by which you can define. But the most important thing is MAFLD definition, which includes overweight, lean, or type 2 diabetes, who may be overweight or not. And these are the differentiating feature between MASLD and MAFLD. As we saw, MAFLD could be lean, obese, or diabetic, while MASLD would require to be under these categories. So, now steatotic liver disease occupies the center stage as far as liver disease is concerned. MASLD or MASLD and increased alcohol intake, or ALD, these are all part of the big umbrella steatotic liver disease. Most of the studies suggest a near complete overlap between MASLD and NAFLD, and therefore all the recommendations in the AASLD practice guideline can be applied to patients with MASLD and MSH. However, the reverse is not true. Everything that is applied to MASLD and MSH do not apply to NAFLD. So one can say MASLD takes into its umbrella NAFLD also. Let's look at the epidemiology. So, MASLD is now the most common cause of chronic liver disease, 4 to 10 times higher in patients with metabolic syndrome. 20 to 25% of patients would develop steatohepatitis. 6% of patients would develop cirrhosis. 1 to 2% of patients would develop hepatocellular carcinoma, more in males. So, does this mean that MASLD has only to do with liver? No, it has not only to do with liver, although variceal bleed, ascites, hepatic encephalopathy, and hepatocellular carcinoma are the common complication. How common is MASLD? Look at the recent prevalence. Global prevalence is 25%, while in India it is nearly 40%. North India 29.1, East India 14.5, 25.2% in West India, and highest in South India around 40%. And lots of studies have come out, even Indian studies suggest that every third person in India is having fatty liver. As I told you, what is more important is not only MASLD having liver complications, but it is a precursor of type 2 diabetes. A meta-analysis conducted in 2000 and 2017 showed that patients suffering from MASLD recognized by ultrasonography are more than twice as likely to develop type 2 diabetes than those without NAFLD. What does it mean? The moment you see fatty liver on sonography, you should start thinking about the person as a potential risk of developing type 2 diabetes, even if he is a lean fellow. The other way around, More severe the steatosis and fibrosis, higher is the risk of type 2 diabetes. And if a patient of type 2 diabetes has fatty liver, reverse, he is more likely to develop hepatic cirrhosis, hepatocellular carcinoma, and death. So, the same thing shown here, patient having no diabetes, NAFLD to NASH conversion is 20%, NASH to cirrhosis 10%, 3% develop hepatocellular carcinoma, and then 43% of the hepatocellular carcinoma die. This is if the patient does not have diabetes. But what if the patient has diabetes? Look at the conversion rate. NAFLD to NASH 40%, and the mortality is 80%. Right? So, if the patient has diabetes, liver complications in fatty liver are high. If the patient has fatty liver, chances of developing diabetes are 2 to 3 times higher. So, how do we encounter MASLD? Either we encounter it by accidental diagnosis of fat in liver, which can progress to hepatic complication and or cardiovascular, renal or metabolic complication. As has been shown in red figures, we can also encounter MASLD by diagnosis of cardiometabolic risk factors, patient obese, patient diabetic, patient hypertensive, patient dyslipidemic, and all of them have high chances of development of fat in liver and therefore hepatic complication. So now it's a double-edged sword, as you can see here. Let's look at, in short, etiopathogenesis. Insulin resistance is a driving force. Previously, we were believing that those who are having type 2 diabetes, having heterogeneous dyslipidemia, develop NAFLD. But now we have realized that those who are having NAFLD, that means fat in liver, they develop type 2 diabetes also. So, NAFLD or MASLD is a bidirectional analysis. On one side, type 2 diabetes patient can develop NAFLD. NAFLD patient can develop type 2 diabetes. NAFLD patient can develop cardiovascular disease. Cardiovascular disease patients can develop NAFLD. Ultimately, they are all diseases of insulin resistance and adipose tissue. Clinical features, very simple and short. Most of the patients are asymptomatic, detected accidentally during routine sonography for something else. Some present with right upper quadrant abdominal pain. Hepatomegaly may or may not be there. How do you work up and investigate? Again, first and foremost would be to rule out the history of alcoholism, and that can be done very easily by asking the patient, taking him into confidence. The initial evaluation would take into account the weight history, medical comorbidities, recent and current medications. Why do we need to know medications? Because drug induced liver injuries should be ruled out. DILI, before you diagnose MASLD. Family history of type 2 diabetes or family history of liver, fatty liver or cirrhosis. You also need to screen for obstructive sleep apnea, alcohol use. Physical examination from BMI to liver palpation to the features of insulin resistance like acanthosis nigricans and features of advanced liver disease. And then laboratory test, as we'll see later on. Screening is recommended for advanced fibrosis in high-risk patients. So if the patient has type 2 diabetes, medically complicated obesity, NAFLD, or first-degree relative with cirrhosis, they all should go for fibrosis screening. How do we diagnose? As I told you, commonest way to diagnose is ultrasonography. It's the first diagnostic tool for fatty liver, easily available, low cost, at least in our setup. What are the limitations? Low specificity because it depends upon the performer's capacity. Can't differentiate between steatosis and fibrosis. It can only say that there is fatty liver. And operator dependent because the person who does the sonography would not be able to exactly tell the results. Other non-invasive tests could be CT and MRI, especially MRI PDEF, which is more or less a research tool. Most important is FIB-4 score. Very important. FIB-4 score can be detected by age in years multiplied by AST, that is SGPT, divided by platelet count, SGOT divided by platelet count into square root of SGOT. If it is less than 1.3, there are low chances of fibrosis. If it is between 1.3 and 2.67, high chances of fibrosis or indeterminate. But more than 2.67, you have to go for fibroscan. There are other parameters also like EPRI score, which requires more inputs from the investigation side, or FIB-4 score. You can have NFS score, that is NAFLD fibrosis score, which also requires, in addition to BMI, it requires impaired fasting glucose or it requires serum albumin levels. It is more specific. So MASLD fibrosis score, that is NFS, or FIB-4 score combined have the highest probability of diagnosing the possibility of prognosis. ELF score is another score which can be detected with the help of hyaluronic acid, tissue inhibitor of metalloproteinase, and N-terminal procollagen, which is again a research tool. Fibroscan. Those who are having FIB-4 score more than 2.7 must undergo fibroscan because it is the most common method to assess the liver stiffness and to detect fibrosis. Sonography cannot detect stiffness and fibrosis, while fibros can do it, and therefore all patients having high FIB-4 score should undergo fibroscan. Transient elastography is even more specific test. MRE is generally not required in most of the cases. Liver biopsy is although gold standard and most important way to define the efficacy of drugs. However, it's an invasive procedure having some serious complication and therefore it is not being practiced routinely. Let's see how to screen. We are always becoming confused when we see so many screening tests. But the answer is very simple, which score to prefer. And when you see that the specificity of different scoring system, the FIB-4 score is probably the most specific and sensitive, which can determine the possibility of development of fibrosis in case of fatty liver, and therefore FIB-4 first should be the strategy for all of us in Indian setup. Screening is most important step, and remember, all bigger institutions now suggest it. AASLD says in type 2 diabetes, suspect NAFLD and NASH and determine patient's risk of advanced fibrosis, increasing number of metabolic disease because increasing risk of progressive liver disease. EASL, ESD, EASO also suggest the same NAFLD screening. ADA also says the same. ADA 2023 said that all patients having type 2 diabetes should be screened for non-alcoholic fatty liver disease or MASLD with clinically significant fibrosis defined with FIB-4 score. RSSDI, our own Indian guidelines, strongly suggest that all patients having type 2 diabetes must undergo diagnosis of fatty liver, that is with the help of FIB-4 score. ADA 2024 and even 2025 have also come out with this very important chart which says that go for FIB-4 score in all patients having diabetes, low risk, that is more less than 1.4, repeat every 2 to 3 years, indeterminate risk, go for fibroscan, high risk, go for fibroscan, and just look for cirrhosis. And this is another very important chart which says that FIB-4 score more than 1.3 requires further workup in all patients having diabetes. How do we manage? Very important. The most effective non-pharmacological treatment approaches for people with MASLD include the weight loss. How much weight loss? We'll see. So, this is the overview of management. We need to do a lot of things while managing NAFLD or MASLD. What are they? Apart from history, physical examination, and ruling out secondary causes, we need to screen all patients having prediabetes or diabetes, obesity, more than two cardiometabolic risk factors, and hepatic steatosis with FIB4 score. What do we need to do? Prevent cardiovascular disease and prevent hepatic complication, right? So this is how we manage. And therefore, when we see pre-diabetes, type 2 diabetes, obesity, fatty liver, high FIB4 score, we need to manage, as you can see in this yellow portion, obesity, diabetes, hypertension, and dyslipidemia. How do we do? We'll see in nutshell. Diet and exercise, pharmacotherapy, and management of all these important comorbidities. Commonest way to manage is lifestyle modification, especially diet, and promote the weight loss. 3 to 5% improves steatosis, but more than 10% weight loss over 6 months improves steatohepatitis and may even revert the fibrosis. So your goal while managing fatty liver should be at least 5% weight loss, while managing hepatic fibrosis, which can only be detected by fibroscan, would be to have at least a weight loss of 10%. That can be done obviously with the help of diet, but not only with the help of diet, you require exercise and pharmacotherapy. Few people ask whether fasting for fatty liver, especially intermittent fasting, help. In theory, yes, but in practice, in trials, it has not proved to be of much use. So let's see one by one. How do we manage diabetes in a patient having MASLD? Apart from weight loss, dietary management, individual A1C target, what is important is this fourth row, which says that you have to select the drug, and the drug to be selected would be pioglitazone, GLP-1 receptor agonist, and SGLT2 inhibitors. For what? If a diabetic patient having fatty liver has low risk, that is FIB4 score less than 1.3, you select these three drugs to reduce the conversion to high risk. Indeterminate risk, once again, the selection remains the same, but strongly recommend GLP-1 receptor agonist because they lead to weight loss. High risk, important thing would be GLP-1 receptor agonist and pioglitazone. So this would be the selection of drugs when it comes to management of diabetes in NAFLD. That does not mean that you cannot use other drugs, but these drugs must be there in the management of type 2 diabetes having NAFLD. How do you manage weight? Obviously, once again, general measures, lifestyle changes, diet, exercise. But when you select drugs, obviously here, SGLT2 inhibitors and pioglitazone would not have much role to play. It would be GLP-1 receptor agonist, which would be very, very helpful. And tirzepatide, which is coming in. How do you manage hypertension in NAFLD? Again, apart from general goals, lifestyle changes, diet, important pharmacotherapy would be ACE/ARB in all circumstances, whether the patient is low risk, meaning thereby FIB4 less than 1.3, intermediate risk, FIB4 risk between 1.3 and 2.67, or high risk. The drug of choice would be ACE and ARB. And how do we manage dyslipidemia? Statin, and only statin, moderate to high risk, high grade statins as initial therapy. How do you manage hepatic complication? We saw management of diabetes, obesity, hypertension, and dyslipidemia in patients having MASLD. But how do you manage hepatic complication? Well, once again, divide them into low risk, intermediate risk, and high risk, and then accordingly select the drugs. We know of three drugs, metformin, vitamin E, and pioglitazone. How do they work? Most of them have insufficient evidences. You take up any guideline, ESL, NICE, Asia Pacific, AISF, or ASLD. All of them say that they've got very limited evidences. Let's see whether it is true or not. But important thing is UDSA, UDCA, and other things that we generally use are strictly, completely, specifically, all guidelines have said they are not indicated and should not be used. So let's look at what are the drugs that have been approved. Vitamin E has not been approved. However, it has shown some good response when it comes to hepatic fibrosis. Right, dose is 800 IU per day in two divided doses. Pioglitazone has definitely shown to be a specific drug, and seroglitazone has Indian trials only. So, how do we manage in nutshell? This is MASLD or MFLD without cirrhosis. Go for resmetirom. What is resmetirom? We'll see in next slide. MASH with compensated cirrhosis. Go for liver transplantation. How do you manage type 2 diabetes in MASLD with or without cirrhosis? GLP-1 receptor agonist, SGLT2 inhibitors, pioglitazone, and insulin. Statin for dyslipidemia, and GLP-1 or bariatric surgery for weight reduction. Resmetirom. Actually, it's a drug. It's a thyroid hormone receptor beta agonist, which has completely changed the scenario. It's an oral tablet to be taken once a day, and it's a very small molecule. In combination with diet and exercise, it has completely revolutionized the management of MASLD and MSH. Remember, the drug would be coming to India in a very short span. There are three important trials: MISTRO-NASH, MISTRO-NAFLD1, and ongoing MISTRO-NASH outcome. We cannot go into details of each, but this is one important trial, MISTRO-NASH, which has shown excellent results of resmetirom. What does the results say? The results say that in many cases, even the fibrosis started reversing as far as resmetirom in MASH and MASLD is concerned. Another drug is denifenstat that will also be coming. Lots of other agents have been tried, starting from caffeine to polyphenols and lots of other drugs. There is a role of omics in the treatment of NAFLD or MASLD: genomics, epigenomics, transcriptomics, proteomics, metabolomics, lipidomics, and glycomics. Lots of research is going on. You can see there are lots of targets for MASLD. Again, we cannot go, but we are going to have a shower of, or I would say rain of all these drugs in near future because of different receptors that they are targeting. And these are the clinical studies that are going on, starting from tirzepatide to selonsertib with different receptors and different targets. Coming to its association with diabetes. Last few slides. We have seen this slide. Patients having no diabetes and fatty liver or MASLD would progress to ultimately to mortality through the steps of NASH, cirrhosis, hepatocellular carcinoma, and mortality. But the change is very transition is very less. 100 patients of NAFLD, only 10 to 20% will develop NASH. Out of these 20, only 2 would develop cirrhosis. And out of these 2, very few would develop hepatocellular carcinoma. So ultimately, 100% of NAFLD, you will hardly see mortality in 4% of patients. But the same patient of fatty liver seen on sonography, or fatty liver detected by FIB-4 score, has diabetes, the NAFLD to mortality would go up by around 15 to 20%, which is very high. So again, showing the same slide, risk of diabetes increases significantly depending upon the severity of liver fibrosis, and risk of liver fibrosis increases significantly if there is diabetes. So simplifying the approach, if the patient has metabolic disease, screen and work up for NAFLD or MASLD as the chances of fibrosis are higher, and we need to follow up these patients for worsening liver architecture. Right? So metabolic disease, screen for liver. Patient has fatty liver disease, screen for diabetes and work up for metabolic disease because the chances of cardiometabolic diseases are higher. So type 2 diabetes, screen for liver; cardiometabolic disease, screen for liver disease, screen for both. And that is how we should start thinking about. So, a couple of questions Like a patient has long-standing type 2 diabetes and hypertension with steatosis on liver ultrasound. These are relevant findings: high BMI, ALT is 48, AST is 39, albumin 3.5, platelets 112. What further evaluation would you first do for this? And the answer ultimately tries to say is FIF4 score first. So person should undergo FIF4. Because you have got reports also, you can also undergo, in this case, the NFS score also. But the importance is FIF4 score first. Which of the following statements about NASH is accurate? Most of the NAFLD and NASH patients are symptomatic. No. Most of the patients with NAFLD progress to NASH. No. A great proportion of patients with NASH have comorbid obesity. Yes. Not all, but most have comorbid obesity. So, coming to the last part of the story, and that is conclusion. So, take home points. NAFLD or MASLD is the leading cause of chronic liver disease worldwide. NAFLD is now termed MAFLD or MASLD. It's an umbrella term encompassing spectrum of liver pathology as consequence of lipid accumulation and lipotoxicity. We must rule out other causes of liver dysfunction, especially any drugs going on or alcohol. Diagnosis could be non-invasive with the help of sonography, MRI, or invasive with the help of liver biopsy. Always evaluate for coexisting kidney and cardiovascular disease. So, how does it help in our actual clinical practice today? If you find fat in liver, keep an eye on diabetes, hypertension, CKD, obesity, and coronary artery disease. Keep on looking for it. 6 monthly follow up. Keep on regularly checking for HbA1c, regularly check for blood pressure, keep an eye on EGFR, keep an eye on BMI, and look for asymptomatic cardiac disease. Fat in liver. Fat in liver. If you find fatty liver, 5% or more fat in liver, start intensive control of diabetes if the patient has diabetes, intensive control of blood pressure, intensive control of weight, and importantly, intensive control of dyslipidemia. Fat in liver, how do we treat? Diet, lifestyle changes, exercise, and drugs like pioglitazone, vitamin E, and resmetirom. Never forget to manage the cardiometabolic risk. What if the patient has not fat in liver but cardiometabolic risk? Always send this patient for FIF4 score. Very easy to do, but every patient having hypertension, dyslipidemia, obesity, or diabetes must undergo 6 monthly or yearly FIF4 score, as has been shown here. So, conclusion of the day: in 2017, hepatocellular carcinoma was occupying the center stage with few hepatitis on one side. NAFLD was a neglected area of target. Alcohol was even more important, and hepatitis B and C were important. Once we have got victory over hepatitis B and C, now in next 5 years, what we are going to see is MASLD, less of hepatocellular carcinoma because of proper management of MAFLD or MASLD. Alcohol would continue to do, HCV and HBV would go down. Thank you very much. That is where we will stop.
Thank you so much, sir. Thank you for your overwhelming talk that you have shared on our platform and for making our viewers understand about the topic in such a better manner. We have received few questions from the participants. So, with all your due permission, I would like to put across those questions to you.
Sure.
So, the first question is related to the liver biopsy. So, when is a liver biopsy necessary, and are there non invasive tests that can adequately assess the degree of liver damage? If you can put some light on it, sir.
Sure. Liver biopsy is basically non-invasive. It has got its own side effects or problems, as we said, with bleeding, possibility of bleeding also. While doing liver biopsy, you may not be able to exactly reach the fibrosis area, and therefore, occasionally, liver biopsy may be falsely negative. We have got till the better alternatives were not available. Liver biopsy was considered to be the gold standard. And remember, all the drug trials starting from pioglitazone to seroglitazar to the remicetron, are all based on liver biopsy only. But now we have got two important parameters. One is fibroscan. So if your patient's FIB4 score is more than 2.7, you can send the patient for fibroscan, which can very perfectly determine two things: stiffness of the liver and fibrosis, amount of fibrosis that has developed. So, with the advent of fibroscan, the need for liver biopsy is solely restricted to the research or trials for clinical judgment. Liver stiffness, fibroscan is the most important clinical gold standard tool. So go for FIB4 score more than 2.7, send the patient for fibroscan, and that would give you exactly the clue whether the patient has developed fibrosis. That is where you need to be very proactive and start the lifestyle changes, diet, exercise, pioglitazone, because it has a proven effect. Along with that, intensive control of diabetes, blood pressure, weight, dyslipidemia, and no sooner the resmetirom is available, start it.
Thank you so much, sir. Thank you for answering that question. Moving ahead with the other question. And the other question is related to imaging techniques. So, what imaging techniques should one use to diagnose hepatic steatosis in their patient?
Well, you should have a good sonographer. Any good sonographer will be able to pick up the fatty liver, that is fat in liver. The moment fat in liver is more than 5%, any sonographer would pick up. Then why did I say that sonography is not very specific or sensitive, or it has got observer's bias? The answer is, while thinking about grading the fatty liver, grade 1, 2, 3, there is lots of observers issues. Even the angle of sonography would change. So, for diagnosis of fatty liver, sonography is the best screening tool. For judging the quantity of fat in the liver, you require fibroscan. So only two important things. If you can afford MRI, that is also an important tool which can detect the exact amount of fat in liver with MR elastography, which is also being done in metro cities. But to me, they are not needed. What you need is a good sonographer with a good sonography. One, and if need be, fibroscan if you find fatty liver of any grade on sonography. So only two imaging services are required.
Thank you so much, sir. Thank you for answering that question. Moving ahead with the other question, and the question is related to the management and lifestyle intervention. So, what is the role of weight loss in the treatment of NAFLD and MASLD?
So, since we have received direct trial, you all know where there was a caloric restriction done up to the extent of 800 calorie per day instead of 2200 calories that we take. And we could reduce the weight by 15% for the first time with the help, or rather, without any surgical intervention. That was direct trial. And the direct trial showed that you can reduce, apart from remission of diabetes, it could also show the subgroup analysis that the fat in liver disappeared, the fibrosis in liver reverted. Now this was something unthinkable 10 years back, just as it was unthinkable of reverting kidney disease. Same way, it was unthinkable that once fibrosis occurs, it never reverts. But 15% weight reduction led to reversal of fibrosis and disappearance of fat from the liver. It was also realized that once the fat disappears, the remission of diabetes follows, which means the disappearance of fat from the liver was a precursor of diabetes or remission of diabetes. And therefore, it was concluded that at least you require 15% weight reduction as far as lifestyle changes in fatty liver is concerned. Now, it is not possible to follow the direct trial because nobody can take 800 calories per day. That is not feasible, and most of the patients also drop down. So, what you can do is, instead of going to 800 calories per day, you can take the other option, reducing 500 calories per day from the person's daily requirement. So, if he is taking 1800 calories per day, cut down his calories to 1300 calories per day along with exercise, and most of the time you will start getting a reduction of 5 to 7% weight loss, and that should suffice if the patient does not have fibrosis. Add to it the better drugs that are available: pioglitazone, GLP-1 receptor agonist, that is semaglutide for the time being in India, injectable semaglutide if it comes, and then dual receptor blocker tirzepatide, which would be launched in India next year. So weight loss of 5 to 7% with diet, 500 calorie restriction, exercise 30 to 60 minutes per day, intensive exercise, and pharmacotherapy, pioglitazone, GLP-1 receptor agonist, semaglutide for the time being, and tirzepatide when it comes, should suffice for reversal of fibrosis and completely eliminating fat from the liver.
Thank you so much, sir. Thank you for answering that question and all the other questions for our viewers and for making them understand about the topic in such a better manner. I would like to thank all of our viewers for their ardent participation that they have shown by staying tuned with us throughout the session and putting across such interesting questions to us. And also, I would like to thank you, sir, for taking out your valuable time and for being here at our platform and sharing such wonderful insights with us with all your weekly presentation that you have shared. We hope that our viewers must have got the benefit that they were here for from your talk, and we will be looking forward for such more impressive talks from your end in your future, sir. So, before we conclude, sir, any last take home message from your end?
Take home message only to: the moment you see fat in liver, the moment you see fat in liver, start thinking about metabolic risk factors in that person, meaning thereby check for diabetes, check for blood pressure, check for weight, and check for lipids. Avoid smoking alcohol. The moment you see hypertensive patient, diabetic patient, obese patient, dyslipidemic patient, patients having alcohol or patient having history of cirrhosis in the family, immediately go for FIB4 score every yearly. And if it is more than 2.7, send the patient for fibroscan. So, fatty liver, metabolic changes, fatty liver. Thank you.
Thank you so much, sir. Thank you. With this, and with the note of this, we are concluding the session here for today. Until next time. Thank you so much, sir.
Thank you, IJCP Group, and thanks all our viewers. Thank you very much.